We are talking about the errors which can occur because of an improper positioning of the patient or because of instructions not being given to the patients appropriately. So majority of these errors are technique based errors which we forget to instruct the patient or forget to do when we adjust the patient, or if you are unaware about the actual positioning of the patient in the machine. So, what all errors can we expect? So, to know what is the errors, you have to know what is the normal. So, this is the normal appearance of the structures that you see in the panoramic radiograph. And you know that there are some guidelines which you have to follow regarding the mid-sagittal plane, the Frankfort's horizontal plane, or you can say the canthomyatal line. Also, the biting of the patient on the bite block, making the patient hold on the support arms, the headrest, the chin rest, all these components, as well as the patient's position standing straight with the neck erect, all of them will help us to get a good image on the radiograph. Also, with wearing a lead apron without a thyroid collar. Okay, so if any of these things are not focused, we can get errors. So the common errors that we are going to deal with, one is with the patient preparation. So the first thing is the ghost images. You might be knowing about the term ghost. Ghost is something which is not there, but you see it appears to be there. Okay, so ghost images are not actually present in the site of the radiograph. For example, if you see a ghost image in the mandible, it is not really present in the mandible. It might be somewhere else, but the image is shown in the mandible. Okay, so when does this ghost image occur? During the patient preparation, we have to instruct the patient to remove all metallic objects like earrings, nose pins, or any metallic instruments that they are using from the head and neck region, including the eyeglasses, earrings, necklaces, piercing jewelry, removable partial denture, especially with the clasps, and orthodontic retainers, which are removable, hearing aids. So, all of these, if they are not removed from the patient before the exposure, you get to see a ghost image appearing on the opposite side of the film. If the patient forgot to remove the hearing aid on the right side, the ghost image will be seen on the left side. So, what do you have to do? The solution to this problem is to instruct the patient to remove all the objects from the head and neck region before you position the patient into the panoramic unit. Okay, so in this image, you can see the arrows. So the left arrow over here, it is the earring which has been worn by the patient. The right, sorry, the right side of the patient, okay? The right earring that you see here, the ghost image of the right earring, you see it on the opposite side. So when you see it on the opposite side, it is larger in size, it's almost of the same shape, but it is not sharp, it is having distortion. It is also at a higher level than the actual object. Here it is the earring, okay? And less sharp, also less distinct, less clear, but of the same size and shape. Okay, so these ghost images, always remember they are occurring on the opposite side as that of the object. It will be of same shape, larger in size, less clear, and always projected higher than the actual image. Okay, so here the left side earring has been masked by this black image over here. So the artifact or the ghost image of the left side earring will be seen on the right side here. So as you can see, the shape is distorted. So this object is not present in the maxilla or the mandible, but it appears to be there because you forgot to instruct the patient to remove the earrings. Okay. So the problem with ghost images is that it compromises the diagnostic quality. If a dentist doesn't know about the ghost image, then he may do a improper diagnosis and improper management of the case. Okay, so you have to always instruct the patient to avoid the appearance of ghost images on the radiograph. Next is patient preparation, lead apron artifact. Now, if the lead apron is incorrectly placed, or if you use a lead apron with a thyroid collar as we use in the intraoral imaging, then you get the lead apron artifact. Okay, so if you see a triangle shaped radio opaque area in the center of a panoramic imaging, it means it is the lead apron artifact. Okay, so the solution to this is make the patient wear the lead apron without the thyroid collar. Okay, so if you wear the lead apron with the thyroid collar, it's going to block the x-rays with the help of or with the use of the thyroid collar. So the expected outcome is this triangular shaped radio opaque area. Okay, so next is about lips and the tongue. So you have to always instruct the patient to touch the tongue towards the palate and swallow. Also, to make the teeth in close contact, and also you have to ask the patient to exhale the air from the nose during the exposure. When we do it, we will not see this black area as pointed by the arrows. So, if you see it, that means that the patient is not touching the tongue towards the palate. If it's not touching the tongue towards the palate, you can see the upper black line over here. So the white area here, upper one is the hard palate. The lower white area is the shadow of the tongue, and the black area here is the air space between the palate and the tongue. So that's why we ask the patient to touch the tongue towards the palate so that this black area is not seen. So this can be easily misdiagnosed as a fracture line. So any error in panoramic imaging, we have a problem with the diagnosis. If the lip is not sealed, again, you can see a small black area between the upper and the lower teeth extending to the sides. So you have to also ask the patient to close the lips so that you do not see any air column in the panoramic radiographs. Okay, so that's about the error due to the lips and the tongue. Now it's about the patient positioning. So previously it was about the patient preparation. So now we have come to patient positioning. The first one is the lip and the tongue. Chin too high. You know that when you adjust the Frankfort's horizontal plane parallel to the floor, the head of the patient is tilted little bit down to make the Frankfort's horizontal plane parallel to the floor. So, if the Frankfort's plane is incorrect and the patient's chin is positioned too high, that means instead of head tipping down, the head is tipping up. So, you get a reverse smile line. So, what is reverse smile line? This area, which is marked by the red color here. Okay, this is called as a reverse smile line. So how to correct it? You have to position the patient so that the Frankfurt's plane is parallel to the floor. If the Frankfurt's plane is parallel to the floor, that means head will be tipped a little bit down. If the head is up, then you can definitely expect a reverse smile line. Also, if you see the mandible, it is appearing stretched to the sides. Okay, so you do not see the normal curvature of the mandible in this kind of errors. The next error in the patient posturing is chin too low. So Frankfurt's horizontal plane should be only parallel to the floor. That means head tipped little down, which makes the canthomietal line at 10 degrees to the floor. So here, the patient is standing with the head too down. So what is the problem? If you imagine yourself standing with the head too down, you can expect that the chin is going to get cut in the radiograph. So what you see here is an exaggerated smile line. Exaggerated means that the normal smile line for a panoramic radiograph will be somewhat like this. Okay, in exaggerated, you can see that it is like this. Okay, the curve goes back. So this is called as an exaggerated smile line. So what you have to do, you have to correct the patient to a normal Frankfurt's plane position. Okay, so if the head is high, the chin is going to get stretched, and also with that the teeth are also going to get stretched, and you get a reverse smile line. If the head is too down, then you are going to get the chin cut with an exaggerated smile line. Okay, so if you see this error, you have to reposition the patient with the correct position of the Frankfurt's horizontal plane. The next error that can occur is posterior to the focal trough position. So we know that we have to instruct the patient to bite on the bite block. If the patient doesn't bite on the notch of the bite block, that means if the patient's anterior teeth is positioned too back on the bite block or too posterior to the focal trough, then the anterior teeth will appear more stretched or fat and out of the focus of the radiograph. So what do you mean by that? By making the patient bite on the bite block, you are making the patient position in the focal trough. So if the patient is biting too far away from the bite block, notch itself, then it means that your patient radiograph will definitely be not clear. The teeth is going to appear more fatter and the structures are going to appear out of focus. Why? Because the bite block will make the patient stand in the focal trough or the image layer. If the patient doesn't stand, you can get a distorted image like the one that you see. So always make the patient position in such a way that the anterior teeth are placed in an end-to-end position in the groove on the bite block. Okay. Next is if the patient is biting on the bite block but anterior to the focal trough. That means the patient's teeth is not in the groove. If the patient teeth is far away from the groove, the teeth is going to appear more fatter. If the patient's anterior teeth are positioned far forwards, that means a major portion of the bite block is inside the patient's mouth. Or you can say the position of the bite block is anterior to the focal trough. So in such a case, the teeth will appear less thin, or you can say skinny teeth. If the major portion of the bite block is away from your mouth and you are not biting on the notch, that means that you are going to get a fat teeth, a broader teeth. But if you are making the patient bite beyond the notch in the bite block, that means a major portion of the bite block is inside the patient's oral cavity, then the structures can appear more thinner and definitely out of focus as well. Spine, that means the cervical vertebrae not straight. The problem with cervical vertebrae not straight is that it's going to cast the shadow in the midline region. Because the machine turns around the patient, the image of the cervical vertebrae will fall in the midline of the patient in the radiograph. So, if the patient's spine is not straight, that means that you have to instruct the patient to stand or sit as tall as possible to get a good radiograph. Okay, so what is the difference between the lead apron image and the cervical vertebrae? Lead apron image is just a uniformly dense radio opaque area, okay, because of the thyroid collar. In the case of cervical vertebrae, you can see that the image is extending up. In the thyroid collar artifact, the image will be only until the mandibular region. Did you understand? So if the lips is not sealed with the tongues up on the palate, if the patient's spine is not shaped, if there is patient positioning error, like the spine not straight, the spine is drooping, especially in the case of children, you can expect the shadow of the cervical vertebrae and also spine in the side of the radiograph. You will see the cervical vertebrae on two sides of the radiograph if the patient is not made to stand the straight. Okay, so spine not straight is another error. So in the next topic is your cone beam CT, which is actually for your next week, but we are completing this because you are going to do your practical clinical rotation. So you have to know the basics about the cone beam CT. Okay, so cone beam CT is a new technology in which you are going to take 3D imaging rather than the 2D that you have been practicing so far. Okay, 2D intraoral, 2D extraoral. We get only the length and the breadth. If you want the depth, you have to go in for the 3D imaging. So here, the manufacturers can provide softwares that will help make it possible to see all anatomic structures clearly, including soft tissue. So some programs will even overlay the patient's facial image into the radiographic image. What do you mean by that? Overlay means superimpose, okay? So some programs can superimpose or create a structure of the patient's face with the radiographic image as you see in number B. The digital images over here, okay? The digital images can be easily adjusted, manipulated, and colorized on the computer. Because the images are digitized, they can be easily sent over the internet, allowing for collaboration and consultation on the cases. So, how a CBCT machine works? It takes a complete 360 degree rotation. That means it turns around the patient completely. 200 to 600 2D images are taken with the single exposure. They will combine to make it into a 3D image. So, why do we advise CBCT? Because it has lower radiation dose than CT. Scan times vary between 7 and 30 seconds. The duration has become less. The short exposure time decreases the chances for motion artifacts to occur. Motion artifacts, for example, the patient moves, the X-ray tube head moves like that. Okay, so that is also not there. Equipped with devices to stabilize the head and the neck of the patient, and the patient should be given all the oral instructions necessary to remain still and to remove all the removable appliances from the head and neck region. The patient positioning is the same as your panoramic imaging. The spine should be straight. The mid-sagittal plane should be straight or parallel to the receptors. So here, FH plane, very important. If the FH plane is not considered and not positioned correctly, you can get the cut in the mandible. You also have different options to take different sizes of the facial bones. For example, you can take a small size region, a medium sized region, or a large sized region. So these areas are called as field of view images. Okay. Field of view means the area where you want to see the structure. So some doctors will advise, I want a small field of view. So it depends upon the machine whether you are practicing field of view size, that means different size of collimators, or you can either ask maxilla or mandible, or you can ask the whole skull. So, depending upon the requirement, we can change the area of exposure small, medium, large, maxillar, mandible, or all of them. Okay, so the advantage is that it greatly enhances the diagnostic ability of the dentist by providing 3D information. So, they can localize the impacted tooth to be removed and the location of the mandibular nerve, its closeness to the tooth before surgery. So, this will help us to expect any problem. Okay, so common uses of CBCT images. It's used for implant placement. So, implant placement also we will do analysis for nerve, whether the nerve is close to the alveolar bone in which we have to place the implant. Is there, for example, a wisdom tooth, impacted tooth planning? You check the relationship of the nerve with the tooth, the roots, so that when you are surgically removing the tooth, there should not be any problem. So, likewise, when you want to place an implant, you also have to know about the nerve position so that your implant should not hurt the inferior alveolar nerve or the sinus itself. Endodontic assessment, then evaluation of temporomandibular joint, orthodontic evaluation, and also pathology evaluation. So, what are the uses of the CBCT? Any information that you want to know, which is in 3D, you can take it with the help of CBCT. That means surgical planning for impacted teeth, orthodontics, accurate placement of dental implants, that means implant imaging, evaluation of jaw, sinus, nerve canals, and nasal cavity, determining the bone structure and tooth orientation to find out whether there's any complication arising or expected to have from those structures. Locating the origin of pain or pathology, then cephalometric analysis for orthodontics and reconstruction surgeries. So these are the indications where we use these type of images. The last part is your specialized extraoral imaging. So, A standard intraoral X-ray machine may be used for a variety of extraoral projections including transcranial and lateral jump. So transcranial means you're going to take the side of the face and the TMJ. So for the TMJ, we have different methods when we use a film-based extraoral imaging procedure. Okay, so the special head positioning is required along with the beam alignment if you are using an intraoral machine, but if you are using a panoramic unit, you have to fit the special device from the main panoramic unit and fit it to the cephalometric unit. If you remember, when we had the demonstration, the sensor was removed from the panoramic unit and it was fit onto the cephalometric unit. Also, we need to put a head positioner and a cephalostat, which can help in demobilizing the structures. Okay, so films and intensifying screens, when they are used, they are going to use as extraoral projections. That means a crystal film size number 4. You can use it for extraoral radiography as well for some techniques. And we have another one 5 by 8 inch, which we use for extraoral radiographic techniques. However, you know that the films require more radiation than the sensors. So, next concept is the grid. So, grid, it is a device that is used to reduce the amount of scattered radiation that comes from the patient during exposure. So, if you allow the scattered radiation to reach the film, it's going to decrease the contrast and the diagnostic information. Okay, so what are grids? Grids are made of lead. You can see dark purple and light purple strips here. Okay, so once the X-ray exposure falls on the patient, that means primary radiation forms on the patient, which forms secondary radiation. From the face of the patient, you can see the blue lines. These are scattered radiation, which touches the patient and it gets scattered away. So the use of grids, as you can see, will remove the scattered radiation. So this increases the efficacy or diagnostic quality and the contrast of the extraoral film. So grids are composed of series of thin lead strips embedded in plastic. That means inside the plastic they have put the lead strips. Okay, which is alternate. Strips means thin sheet, thin long sheet. The grid is placed between the patient's head and the film, always important. During exposure, the grids permit passage of the beam between the lead strips, and the scattered radiation is produced when the absorbed radiation from the patient, that is the secondary radiation, gets deflected and reaches the film. Okay, so in order to avoid those scattered radiation to reach the film, we are going to use the grids. Okay, so grids, you will definitely get a question in your exam. So grids always reduce the scattered radiation, increases the image clarity, but more exposure to the patient. Okay, exposure time must be increased because of the use of grids, because they are removing the scattered radiation. So that is one disadvantage of the grids that we see. So we have three sections more, that is lateral ceph, PA, and the temporomandibular joint projection, which is the ones that you have to know in your skull radiography. So lateral ceph, PA, and TMJ projection, all of them you can be doing it with the extraoral unit and the cephalostat. So they are difficult to interpret because of the overlying or overlapping anatomic structures that exist in that area. So they are superimposed on one another. In many cases, multiple exposures may be necessary to obtain a clear view of the area which you want to see. So the three main extraoral projections: skull radiography. So here, mid-sagittal plane is parallel to the image receptor. That means the image receptor is on the side or lateral side of the face. So that's how the name lateral radiography. So here the central beam will go from external auditory matters, that means the ear of one side to the other side. Okay, so sometimes if you want soft tissue and hard tissue together, very important. Okay, you call them as lateral cephalogram or lateral cephalography. Okay, now if you want only hard tissue, it's called as true lateral skull. Okay, so if a surgeon asks true lateral skull, means he doesn't need soft tissue. So you can see something called as wedge here. Okay, so wedge filter, when it is used, when you put on the wedge filter, it will block the x-rays to go through the soft tissue profile. If you put it off, then it will allow and give you the soft tissue profile of the face. Okay, so wedge is the one which determines, it's called as the wedge filter, which determines whether the soft tissue will appear on the lateral skull view or not. The next is the PA projection. You can see that the patient's head is touching the film cassette here or the sensor. That means the mid-sagittal plane of the patient is perpendicular to the sensor and to the floor. You can see it here. The mid-sagittal plane is perpendicular to the image receptor. Now the last one is the temporomandibular joint projection, in which you can see the temporomandibular joint very clearly. Okay, this can be open mouth and closed mouth view. So there will be two turns in the extraoral machine. You can take it using CBCT as well. So in one, the mouth will be closed. It will take the exposure only for TMJ region. And in the second one, the mouth will be open as much as possible, and you're going to take a CBCT or an extraoral imaging. So this kind of imaging, in which we get sections of the areas, we call them as tomography. There is the simple tomography and computed tomography and cone beam computed tomography. What is the difference? Simple tomography means you see only the TMJ region and it will be in a 2D imaging. Computed tomography means you see the images in the TCT scans. And cone beam computed tomography means you see the images in CBCT scans. Okay, always CBCT will have a lower radiation exposure than the CT. So dentists prefer to use a CBCT than a CT machine unless you need very much details.